Hi, my name is Taylor Allenby, and I'm presenting on Fibroadenomas and Phyllodes Tumors. To start, we have a patient, NB. She's a 23-year-old female who presents to breast surgery clinic with a palpable breast mass. Her history is significant only for personal history of right breast fibroadenoma, for which she had an excisional biopsy 3 years ago. Her family history is negative for any cancers, and on physical exam, you find a palpable mass in the left breast at the 12 o'clock position above the nipple, and it measures roughly 2 by 1.5 centimeters. So for a patient with a palpable breast mass, here's a list of the differentials that are possible. However, it's important to note that in a patient under 30 with no family history of breast cancers, her differential would likely not be this extensive and would likely only include the first 4 diagnoses. So I'll start with fibroadenomas. These are the most common benign tumor of the breast. They present in women aged 15 to 35 as a well-defined and mobile mass. They can fluctuate with hormonal changes, and 20% of patients have multiple masses in the breast or bilateral breast. The pathology shown in the top image has stromal and epithelial connective tissue cells that are uniformly distributed and no stromal cellular atypia. And in the bottom image, you can see her ultrasound, which shows a well-circumscribed mass, and you can see shadowing at the edges, which is usually associated with benign masses. So fibroadenoma subtypes include juvenile, which are most commonly found in patients aged 10 to 18 and are characterized by rapid growth. Giant fibroadenomas present greater than 5 centimeters in diameter and also have rapid growth. These can commonly be seen in pregnant or lactating women. Complex fibroadenomas have excessive proliferation of epithelial cells and can have proliferative changes that can be worrisome and overlap with a lot of the findings seen with Phyllodes tumors. These are also associated with an increased risk of cancer, so require further workup. Cellular fibroadenomas have a high cellular component as well, and then myxoid fibroadenomas are less common but have stromal components. So the workup for a patient with palpable breast mass depends on age. So in a woman under the age of 30, an ultrasound would be obtained. In a patient over 30, you would get an ultrasound as well as a diagnostic mammogram. Some of these can be monitored for 3 to 6 months with repeat imaging. And then indications for biopsy include any concern for malignancy or Phyllodes, any mass with rapid growth, which is defined by the American College of Radiology as a greater than 20% increase in all 3 dimensions over 6 months, and then any woman who is postmenopausal with a new fibroadenoma or new mass. So 15% of fibroadenomas regress spontaneously in patients with masses that are greater than 3 centimeters or have the rapid growth as I previously described, as well as pathology on core biopsy that show any type of epithelial abnormalities or are inconclusive, because again, a lot of these can overlap with Phyllodes tumors, so require further workup and an excisional biopsy. Some patients prefer to have it removed just because of cosmetic outcomes or because it bothers them. And then these can be treated with excisional biopsy, where the operative goal is enucleation of the tumor and not necessarily obtaining additional shaved margins as well. So going back to our patient, her core biopsy showed findings consistent with a fibroadenoma. So she was monitored with ultrasound and clinical exams. However, hers rapidly grew to the size of 2.5 centimeters from 2 centimeters, and so surgical excision was pursued. Phyllodes tumors represent fewer than 1% of all breast neoplasms, and they present, in contrast to fibroadenomas, in women who are older, between the ages of 42 and 45 most commonly. They have smooth, multinodular, well-defined masses that are mobile and painless, and 20% of these are picked up on screening mammography, while the rest are found on exam. Their pathology shows leaf-like architecture with papillary projections of epithelial-lined stroma, And the stromal elements are key in differentiating Phyllodes tumors from fibroadenomas. It's important to note that the false negative rate for core biopsy can be between 25 and 30%. So if you have a high clinical suspicion for a Phyllodes tumor, it's better to err on the side of excisional biopsy and to work it up to completion. So the WHO classifies Phyllodes tumors as benign, borderline, and malignant, and when grading how aggressive the tumor is, they look at stromal cellularity in regards to its cellular atypia, tumor margins, and margin rate. And as you can see, benign and borderline do not have stromal overgrowth, but have varying degrees of atypia, and malignant have increased atypia, infiltrative margins, and then the presence of stromal overgrowth. And these three can be seen in ascending order on the right. So treatment for Phyllodes tumor, in contrast to fibroadenoma, is a wide local excision with a goal margin of 1 centimeter. Wide local excision has been found to be equivocal to mastectomy for both local recurrence and overall survival, so there's no need to do a mastectomy for a Phyllodes tumor. If it does recur, then you can pursue a salvage mastectomy, but it shouldn't be your initial choice. So with margins, if they're a negative, no additional surgeries or therapies are needed. However, if the patient has positive margins, it depends on what the pathology shows and whether they're benign, borderline, malignant. So benign and borderline can either have a margin re-excision or close surveillance, and malignant is a definitive indication for further surgery with additional margins. Evidence suggests that a positive margin is only correlated with a higher local recurrence rate for malignant tumors, which is why if they're benign or borderline, it's unlikely that the patient will need further surgery. So research hasn't shown a clinical benefit with either adjuvant chemotherapy or hormonal therapy. And then with radiation therapy, it can be done with patients with positive margins. And then in those with negative margins, there's pretty limited data with equivocal findings, but some studies have shown a reduction in local recurrence if radiation therapy is given for only borderline and malignant Phyllodes tumors. So radiation therapy should not be used for benign Phyllodes tumors. And there have been no found or conclusive effects on overall or disease-free survival. Given the small number of patients with malignant Phyllodes tumors of the breast, there are really no evidence-based recommendations for surveillance after therapy. Patients can be monitored with physical exam every 6 months for 2 years with an annual diagnostic mammogram or an ultrasound if they're under 30. Since most recurrences occur in the first 2 years after treatment, we should perform a history and physical exam every 6 months for the first 2 years, and then they can be moved to annual. The overall recurrence rate is about 12% for Phyllodes tumors, and this can range from 8 to 18% based on whether it's benign, borderline, or malignant. Patients with large, meaning greater than 5 centimeters, or malignant Phyllodes tumors are at higher risk for developing metastatic disease, so surveillance should be performed more frequently and usually combines chest x-rays and CTs. And these are based off the guidelines for the NCCN on soft tissue sarcomas. If it does metastasize, it typically goes to the lungs, and then second most commonly is the bone. So here's just kind of an image that represents the workup for Phyllodes tumors based on NCCN guidelines. And here are my references. Thank you very much.